Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio-nerds everywhere are working hard to fight this global epidemic. These are their stories.
Hey CardioNerds, we're excited to bring you the inaugural episode of the Cardio-Rheumatology series here at CardioNerds. This is Rick Ferraro, co-chair of the Cardio-Rheumatology series and cardiovascular imaging fellow at the University of Michigan. Today we'll be talking about the role of inflammation in cardiovascular disease, from the molecule all the way to the bedside. Stay tuned for upcoming episodes focused on cardiovascular risk in patients with rheumatologic conditions, the evidence and data behind targeting inflammation for cardiovascular risk reduction, real-world implementation of anti-inflammatories, and a deep dive into multimodality imaging for systemic inflammation. Today, we're going to focus on the molecular mechanisms linking inflammation to atherosclerotic cardiovascular disease and how inflammation can impact the development and progression of cardiovascular disease. To join our discussion today, we have series lead and co-chair Dr. Gurleen Kaur, new cardiology fellow at Brigham and Women's Hospital, and fantastic CardioNerds Academy APD. Gurleen, great to see you tonight.
Thank you so much, Rick. It's my pleasure to be a part of this discussion, and I'm so excited to welcome CardioNerds inflammation enthusiast, Dr. Ronaldo Correa, who is a CardioNerd Academy House Chief and currently a hospitalist at Brigham and Women's Hospital. It's so great to have you lead the discussion here tonight, Ronaldo.
Hey everyone, so great to be here and be part of this episode. With great excitement, I introduce our expert, Dr. Antonio Abbate, received his medical degree from the University Campus Biomedical and Cardiovascular Medicine training at the College University of the Sacred Heart, Rome, Italy, and also earned a PhD in molecular and cellular cardiology. He then moved to Richmond, Virginia, USA, and completed a residency in internal medicine at the Virginia Commonwealth University and joined the faculty, rising to the rank of professor with tenure. In 2022, Dr. Abbate joined the University of Virginia in Charlottesville, VA, as a Ruth C. Heed Professor of Cardiology in the Burn Cardiovascular Research Center and Heart and Vascular Center. His research is focused on cardio-immunology, and he leads a research team focused on the role of IL-1 and inflammation target treatments for cardiovascular disease. Dr. Abbate, we are so thrilled to have you here on the show and learn from your expertise. Welcome to CardioNerds.
Oh, thank you very much. I'm very happy to be here with you. I'm kind of honored. CardioNerds is a fantastic program. Thank you, Ronaldo, for the kind introduction. Thank you, Gurleen and Rick, for putting this program together. You know, I've been intrigued by inflammation, as I refer to often as the hidden side of the moon, since I was in medical school. Back then, there was an editorial came out in the England Journal of Medicine from Attilio Masri, who was a pioneer in the study of inflammation, commented on a study that had prediction role for C-reactive protein. And the editorial was entitled The Hidden Side of the Moon. And it was really kind of pointing at how we as a community had been looking at atherosclerosis as a lipid disease, but there was at least another part of the story, which was inflammation. I then decided to go ahead and train with Attilio Masri and Filippo Correa in Rome and completed cardiology training and a PhD, as you mentioned, and became kind of obsessed by this idea that we could indeed treat inflammation and make patients better. So knowing that there is a cardio-rheumatology section at CardioNerds make me so incredibly happy. So thank you for having me.
Thank you so much, Dr. Abbate. It's so great to hear about your journey in this space, and we're looking forward to bringing your expertise to our CardioNerds clinic. So let's start off with our first patient in our CardioNerds clinic. We'll be seeing Mr. James. He is a 62-year-old man in a follow-up visit 6 months after he had an anterior STEMI, for which he underwent a percutaneous coronary intervention of the LAD. Since then, he's been working really hard to take care of himself. His blood pressure is well controlled. He's lost 15 pounds, with his BMI currently being 27. He quit smoking. His last A1C was 5.5%. His LDL is 63 milligram per deciliter. His estimated GFR is 80. And his echocardiogram revealed no wall motion abnormalities with an ejection fraction of 60%. He's also completed cardiac rehab and practices moderate physical activity 5 days per week without any significant symptoms. He's also been taking all of his medications as prescribed, which include aspirin 81 milligrams daily, clopidogrel 75 milligrams daily, atorvastatin 40 milligrams daily, losartan 50 milligrams daily, metoprolol succinate 50 milligrams daily, and semaglutide 2.4 milligrams weekly. He saw online that inflammation may lead to heart attacks and is asking you in clinic how inflammation factors into his risk for recurrent cardiac events. Dr. Abbate, what do you tell patients about the role of inflammation in cardiovascular disease? And what factors in this patient may contribute to the development of inflammation? How do genes and lifestyle contribute to inflammation?
Well, Gurleen, this is really an excellent case, and it's one that I commonly see in my clinical practice. And it kind of shows how patients are having these events, these are adverse cardiovascular events, often now with controlled risk factors, and they're still concerned that there may be at risk for recurrences. And so this is where the concept of inflammatory risk, and particularly residual inflammatory risk, come to play. We know that patients who have had an acute myocardial infarction, especially STEMI, are likely to have elevated C-reactive protein during the indexed event and in the recovery. And we know that the levels of C-reactive protein, which is a widely used inflammatory biomarker, predict many of the adverse events, including recurrent MI, restenosis after PCI, stent thrombosis, heart failure, and death. And so this patient specifically, we already know that he is someone who is at high risk or has been at high risk because he already has had an atherothrombotic event and actually has had one that's life-threatening, ST segment elevation MI. Thankfully, with the improvement of our treatment of these patients, mortality for STEMI has plummeted, which is fantastic. We're treating them with multiple drugs, but they remain at risk for recurrent events or complications for years to come. And so in this case, if we think about residual inflammatory risk, we need to think about C-reactive protein, which is this widely used, readily available, inexpensive inflammatory biomarker. In this case, what we're looking is not whether this patient is at risk or not, but what is the residual risk after the patient has received what we think about first-line treatment. And then we should think, can we do anything else to further reduce this risk? You mentioned this patient is already on dual antiplatelet therapy, as it should be. One of my questions that if I see in this patient is, should this patient be on a more powerful T2Y12 inhibitor like ticagrelor or prasugrel? And if they are on a more powerful inhibitor and now months are going by, is aspirin still needed? These are kind of questions that are not specific to the inflammatory risk, but it's an important question we need to ask in our clinic. You have shown that LDL is really good. It's 63. Should we push even further? If we go less than 50, less than 55, do we get benefit? Probably. What about checking lipoprotein A? Is that a risk marker? It is. And so would that affect our decision to be more aggressive on lipid lowering or to be more aggressive on other treatment? You mentioned he does not have diabetes. His renal function is kind of mild, mildly abnormal, borderline. Would an SGLT2 inhibitor improve this patient's risk? Possibly. He's already on the GLP-1 receptor agonist, semaglutide, which is shown to reduce cardiovascular risk and also have an anti-inflammatory effect. So if I were seeing this patient in clinic, I would tell him that whether or not he had inflammation before an event, it would be difficult to figure out now. Perhaps that could be applied to his family members or his friends. But for him, I would test the high sensitivity C-reactive protein to see what is his residual inflammatory risk at this point when the other risk factors are controlled. What would I do if it's elevated? Well, I would consider colchicine. Colchicine may reduce that risk. I suspect we're going to talk more about it during this podcast, but it is shown to reduce cardiovascular risk in patients with recent MI or with stable coronary artery disease. And I would think that those who have residual inflammatory risk are likely to benefit more, although I cannot exclude that those without elevated C-reactive protein may benefit anyway. This goes hand in hand with residual thrombotic risk, although I find it a little more difficult to quantify what the residual thrombotic risk. but it's certainly something that I think we're going to learn more in the future about using different antiplatelet or antithrombotic strategies. I don't know if I answered your question. Maybe I went a little long, but this is something that I'm really excited about.
Wow, that's amazing. It's such a thorough answer. I'm biased with colchicine. I think it's a great drug, underutilized. A follow-up question that we had, talking about the kind of a history. Over the last 4 decades, there has been increasing evidence that coronary atherosclerosis is not just a disease of passive cholesterol accumulation, but a disease driven by chronic low-grade systemic inflammation. So, Dr. Abbate, can you tell us more about the studies that have helped establish this association and made this concept more a mainstream concept?
Yeah, no, thank you. This is kind of what, drove me to become passionate about cardioimmunology as I was in training in medical school as this new research was coming out. There was a very famous pathologist or pathology researcher in the United States, Russell Ross. Many credit him for a lot of this work on atherosclerosis as defined as a chronic inflammatory disease. I'm sure he is not the only one doing this research. He wrote beautiful reviews, which you can still go ahead and find them. And one that really stuck in my mind was a review in New England Journal of Medicine, where the title was Atherosclerosis is a Chronic Inflammatory Disease, and where he went over the characteristics of several different chronic inflammatory conditions like cirrhosis or pulmonary inflammation, arthritis, and how many of the cellular events that were present in the atherosclerotic plaque were similar to those of chronic inflammation. There was no question at the end of that review that the atherosclerosis is not passive accumulation of plaque. It is a process in which the immune system interacts with the cholesterol in the plaque. And, from there, those decades, a lot of this came from pathologic studies from patients who had died and had atherosclerotic plaque complication, or from specimens that were taken during atherectomy or endarterectomy during surgery. The research became a lot more cellular and molecular. I need to mention at least two of the researchers who've done a lot of this work here, Peter Libby, Goran Hansen, again, and many more. But they started identifying a central role of a component of the innate immunity, as macrophages particularly, but also at the acquired immunity, T cells, and how they interacted with vascular smooth muscle cells in the progression and complication of the plaque. My time came as this knowledge had been acquired in the lab, and biomarker studies were now coming out. Paul Ridker is known for having driven a lot of the research on C-reactive protein. He is a very prolific author and a fantastic researcher. And along the several decades, he's shown how different inflammatory biomarkers, especially in the innate immunity, like C-reactive protein or interleukin-6 or interleukin-1 receptor antagonists as well, predict adverse event in patients with atherosclerosis. And then, parallel to this, because the research is not only bench to bedside, but it's kind of a circle, bench to bedside, back to bench to test more hypothesis, new information, then evaluating it in the bedside. So it's a circle. And so animal models, especially mouse that could be genetically modified, have clarified the central role of the innate immunity in the inflammasome and the cytokines like interleukin-1 beta in the progression of atherosclerotic plaque. So this has been a wonderful journey, again, started from pathology observation to a more detailed immunology investigation to biomarker studies, and then genetically modified mice, and finally therapeutic. So I've been lucky to be alive in cardiology during this time.
Wow, Dr. Abbate, what a spectacular answer, and really just a review from way back up to the current time. I mean, it's so spectacular, and I appreciate some of those references that you gave us of prior researchers and papers to refer to. We can definitely put those in the show notes, and those are definitely things I'd like to read myself. You covered this a little bit, but I'd love to hear a little more of your thoughts on key inflammatory pathways related to the pathobiology and the physiology of atherosclerosis. And how do these relate to potential upcoming or emerging therapeutic targets?
Yeah, no, thank you, Rick. Again, exciting times to be in this field. We're really dwarfs standing on the shoulder of giants that have done this for decades, and so we're at an exciting time where we can see this through. Hopefully, find therapeutic to patients. I mentioned earlier that colchicine has shown to work in multiple clinical trials, but I'm very excited about targeted therapies that are coming along. So again, as I mentioned, the link between inflammation and atherothrombosis has been known for decades due to multiple different studies. What I think was a turning point into the creation of targeted therapeutic strategies is the understanding that the cholesterol crystals could trigger directly inflammation in the innate immune cells like macrophages through activation of the inflammasome. The inflammasome is something that had not been described when I was in medical school. So it's something that has been around now for about 20 years or so, maybe a little bit more. But it's a new understanding on how the cells sense injury, being infectious or non-infection, and process that information, creating a macromolecular structure in the cell that is essential and important in amplifying the inflammatory response, processing key cytokines like interleukin-1 beta and interleukin-18, and actually triggering the death of the cell that has been affected by an inflammatory modality of cell death, pyroptosis. This is another term that I did not learn in school. We were taught that there was either apoptosis or necrosis, but actually we know now there's many different modalities of cell death, including pyroptosis, where the inflammatory signals trigger the death of the cell in a programmed way, like apoptosis, but then lead to the release of pro-inflammatory mediators outside the cell. And therefore, it is not a silent cell like apoptosis, but a more of a dramatic modality of death, more like necrosis. And so now we know that the inflammasome structure is involved in this sensing process. That can be targeted. And actually, I'll tell you, the colchicine, among the different mechanisms of action, it also interferes with the assembly of the inflammasome. But we know also that there are key cytokines like interleukin-1 beta, and there are downstream cytokines like interleukin-6. And so I'm sure that many of you have already heard that the CANTOS trial has targeted interleukin-1 beta with a monoclonal antibody called canakinumab. And that was a study led by Dr. Ritker and Dr. Libby. And it showed a statistically significant reduction in recurrent atherothrombotic events in patients with a prior MI and residual inflammatory risk. That drug, canakinumab, is approved for other indications, but it's not approved for treatment of patients with coronary artery disease. There are more studies now ongoing with a different drug, ziltivekimab, which is a monoclonal antibody against interleukin-6, which is a secondary cytokine downstream of IL-1 beta. We're all excited to see what those studies are going to show.
Dr. Abbate, thank you so much for walking us through the complex metabolic and immune and inflammatory process of atherosclerosis. And I think we've been mentioning this a lot during the episode so far, that one of the main therapeutic focuses to date has always been cholesterol-lowering therapies. But we know that residual risk exists even on top of standard of care first-line lipid-lowering therapies, like you mentioned earlier. And you touched upon this a little bit, how inflammation may be the inciting atherosclerotic process, but also how there's an interplay between inflammatory pathways and pathways that are related to atherosclerosis in other ways. Could you expand a little bit more about how inflammation can be the inciting factor versus how it's kind of amplified by other pathways? And how should we be thinking about this when we see patients in terms of both lipid lowering as well as targeting inflammation?
And it's a great point, Gurleen. I've had the pleasure to see the success of the statins in patients at risk for coronary artery disease or after an event. So if I look back at my memories from when I was a fellow, we were seeing patients with very elevated levels of cholesterol coming in with an acute coronary syndrome. And it was kind of clear that hypercholesterolemia was triggering those events. Now, due to successes of primary prevention, we're actually having better controlled cholesterol levels in patients. So now most of the patients that come with an acute event have relatively normal level of LDL cholesterol. And that tells that story that, while hypercholesterolemia is a key, important, and modifiable factor in atherothrombosis, it's not the only factor. And so in these patients, likely other factors with either lipid moieties, like we mentioned earlier, like a lipoprotein A, or inflammatory mechanism are involved. And again, without taking anything away from their lipid lowering strategies, which is short of success, there is a consideration that in some patients, a pro-inflammatory milieu is really central to the formation, progression, and complication of atherosclerotic plaque. I think we have known for decades that viral illnesses can precede an coronary syndrome event. We've learned that influenza vaccination can actually reduce the risk of acute coronary syndrome. But I think the confirmation of this was actually in the COVID pandemic. The risk of having an atherothrombotic event or actually venous thrombotic event during COVID or after COVID was significantly higher for a period as long as 1 year. And that's unlikely to be related to any lipid effect. So it's where this kind of a proof that the pro-inflammatory changes and likely prothrombotic changes with COVID give a risk of an acute coronary syndrome. Along these lines, we're not at a point where we can easily track the risk on each patient or check the risk over time. We know the C-reactive protein is a reasonable marker, but it tended to change during an event. And so we have to be careful about whether we're interpreting the acute C-reactive protein levels versus the residual C-reactive protein after the healing. And those patients with elevated levels may need different treatments at different times.
Thank you very much, Dr. Abbate. And talking about this, beyond the atherogenesis, inflammation is also related to thrombosis with implications for cardiovascular disease. Can you walk us through how inflammation may induce a prothrombotic state and how that may be an important molecular mechanism as we think about cardiovascular disease?
Yeah, no, definitely. I kind of hinted earlier about what we learned during COVID. And unfortunately, the COVID-19 was a devastating pandemic for all of us, but it did give us an opportunity to really understand better how inflammation and thrombosis speak to each other. And there are two terminology that we are now using more frequently than before. One is the concept of immunothrombosis, and the other one is a thromboinflammation. So I think they both hint to the fact that the inflammation and the thrombotic cascade are linked. There's no doubt there. What is the teleological reason for having inflammation and thrombosis link? Well, if you think about why the human species or the mammals have developed this complicated inflammatory response, is mostly to fight infection or fight presumed infection, prevent bleeding. The humans in the millennia were less likely to die of an acute coronary event. They were more likely to die of bleeding from trauma or a superimposed infection from an animal bite or from getting hurt in the wood. And so the inflammatory response, while protective, has become a little exuberant, where initially it was supposed to fight a presumed infection. Now that we're having a sterile inflammation, like during a heart attack or during the formation of a plaque, this inflammation may become exuberant. And what was needed in the past to stop the injury by creating clotting factors, because it was meant to prevent people from bleeding out, is actually not necessary, as these injuries are inside our body. And so they're causing thrombosis in areas where we don't want thrombose, like in arteries and veins. And so this process that has protected the species for millennia has now become exuberant and unnecessary, as the injury are inside our vessel. And these are local factors. There's also systemic factors. We mentioned earlier that interleukin-6 is a secondary cytokine downstream of interleukin-1 beta. And interleukin-6 affects the production of procoagulants factors in the liver. So we have an increase of secondary reactant that they're predisposed to thrombosis. Put it all together now, you have localized inflammatory signals that tell the endothelial cells to become prothrombotic. You have leukocytes and platelets that are activated and they're more sticky, allow me to term. You have an impaired vasodilatation and you have a more coagulable blood. This all together predisposes to a thrombotic event in the setting of inflammation. And likely the factors that are coming from the thrombosis are also then leading to further inflammation. So it's kind of a perfect storm.
Dr. Abbate, it was such an incredible discussion. And one thing I wanted to kind of highlight, or something that I picked up on, was this point about kind of natural defenses that are getting, in our current era, kind of turned against the body in a negative way. And I think that's something that we see come up in our episodes and in our discussions again and again and again, is that, we've kind of entered a time where the things that were initially adaptive have become maladaptive. And it's such an interesting way to think about things. So one thing we wanted to do is, this is our last case of the day here, but we wanted to go back to the CardioNerds Prevention Clinic to see Mr. Bond. Mr. Bond is a 48-year-old pickleball amateur player who does not smoke or drink alcohol, follows a Mediterranean diet, and has a stable weight at a BMI of 25. He has no known comorbidities or family history of cardiovascular disease. He does have a friend with rheumatoid arthritis who had a recent myocardial infarction and told Mr. Bond about inflammation leading to heart problems. So Mr. Bond wants to know what his inflammation level is. We talked about this a lot already. We've discussed CRP, we've discussed different measures, but in terms of kind of in the clinic, how would you present this to a patient, and how would you recommend using inflammatory markers to assess for chronic systemic inflammation in general in the clinic?
Yeah, thank you, Rick. I mean, I welcome these questions in clinic. I love an engaged patient. I'm also a pickleball amateur, although I'm not that good. So, as someone like this who comes to clinic is welcome. You sit down and chat with them, and you try to kind of reinforce what they're doing well already. They're eating healthy, their weight is stable, they're exercising, they don't have other toxins, which is great. C-reactive protein, we talked about this multiple times. Should we test C-reactive protein? Should we test it in everybody? Maybe. Admit the argument that healthy individuals should have normal C-reactive protein, which is less than 1 or 2 milligram per liter. So if your C-reactive protein is abnormal, there is something not perfect in your body. It could be something transient. You may have had an infection, a viral infection. You could have an allergy bout or something else. So maybe it's reasonable to recheck, especially in someone who's at low risk. But if it is abnormal, there's something that is cooking in there. So what should we do about it? Well, there is a trial that actually addressed this. I mentioned Paul Ridker earlier. He designed this wonderful trial. It's called the Jupiter trial. Now, this patient you just described here doesn't exactly fit the Jupiter trial because the Jupiter included patients with multiple risk factors, a little older, so they enriched the population. Whether the results of the Jupiter, that I'll tell you in a minute, apply also to a lower risk population, we just don't know. What the Jupiter found, that patients who had C-reactive protein more than 2 milligram per liter and had no clear indication to a lipid-lowering strategy benefited greatly, and when I say greatly, I mean really largely, from rosuvastatin 20 milligrams daily. So this is one way that you can address someone with systemic inflammatory marker and risk and reduce it with a commonly used, inexpensive medication, well-tolerated, like rosuvastatin. Now, does that mean that every single patient that has elevated C-reactive protein needs to be treated? Well, it all goes down to risk-benefit. And so if you have a patient with very low risk, then the benefit is going to be pretty small. And therefore, you have to say that every drug has some potential risk. And you may not treat someone who has very low risk. And you go back to say you may not even test that patient. The ideal patient to be tested is someone in which you think the risk may be more moderate and you're trying to define it. If they're high risk already, you already know you're going to be aggressive in treatment, but can help you tailor it. A low-risk individual, maybe not. It's a one-to-one discussion. So this would be something I would talk with Mr. Bond that you presented to me. I love the fact that that Mr. Bond is aware that patients with immune-mediated diseases like rheumatoid arthritis have an increased cardiovascular risk. These are modifiers. So even if other cardiovascular risk factors are not present, someone who has rheumatoid arthritis, and particularly someone who has systemic lupus erythematosus, is at increased risk cardiovascular events. It should be treated to reduce that risk. If you look at young women with lupus, their risk is several-fold higher, like 5 times fold higher than a matching individual without lupus. So we're not talking about an increased risk of 30% or 40%, but of 400, 500%. So that's worth a discussion. There's a very old trial that actually is the one that I mentioned earlier that Attilio Masri had written an editorial for, The Hidden Side of the Moon. The analysis was done by Paul Ridker. It was a secondary analysis of the physician health study with aspirin. This is an old study of I think the 90s, where they took physicians that were apparently healthy. If I remember correctly, it had to be about 40 years of age or older. And they've given aspirin to prevent the first cardiovascular event. The trial overall was, borderline, marginally positive, not overwhelming. But what the analysis showed and that's the paper from Paul Ridker in New England Journal of Medicine, I think 1997, showed that if you had elevated C-reactive protein, your risk was significantly higher than normal therapy, and it was significantly mitigated by aspirin. Again, it's a secondary analysis, but that could suggest that in a patient with inflammatory risk, aspirin may reduce some of the risk. Is C-reactive protein the only biomarker? No. Is it a great biomarker? I think so. It's widely available. It's been validated in multiple studies. But of course, there's nothing specific about cardiac in the HS-CRP. So although people refer to cardiac CRP, there's nothing cardiac about it. It's a systemic risk. And so other systemic biomarkers may be just as helpful. And if you have those, you can use those. If you have to choose one, you probably go with HS-CRP. Another comment would be lipoprotein A. I mentioned it earlier. We're learning more about this. But if you have elevated lipoprotein A levels, you are at increased risk of atherosclerosis. We don't know exactly what to do about it right now, but it's worth discussing. In a patient like this, I would certainly offer it. We know other biomarkers like uric acid, it's more of a marker than a mediator. When we try to reduce uric acid with allopurinol, we don't seem to really affect the risk. So this is the kind of patient I'd like, someone who is engaged in their health and wants to learn more. And I would be very open with this kind of patient to share what we know and what we don't know and have them decide what they think best for themselves.
That's a great discussion. Also, to follow up, we have another patient in our clinic. So on the same day in clinic, we see Mr. Jones. She's a 78 years old lady, 1 week after her discharge from acute coronary syndrome. During inpatient, left heart cath showed multivessel disease. She was not a candidate for CABG due to poor functional status and did not want to undergo stage high-risk PCR, and was not able to initiate cardiac rehabilitation due to severe knee osteoarthritis. She mentioned chest discomfort on going up 2 flights of stairs. A TTE 3 months ago showed a stable EF of 40%. She's on clopidogrel 75 milligrams daily, Lipitor 80 milligrams daily, losartan 50 milligrams daily, metoprolol succinate 50 milligrams daily, spironolactone 25 twice a day, empagliflozin 10 milligrams daily, and semaglutide 2 milligrams weekly. Currently, BP is 95/60 millimeters mercury. She does not smoke. Last A1C was 7.7%, and LDL 68 milligrams per deciliter. Her estimated GFR is 45. Her son is with her and asked if colchicine would be an option for her mother. What are your thoughts, Dr. Abbate?
Well, this is a challenging case here. I hope that all of you with me on this panel and all of you listening are realizing this patient is a high risk patient. This patient had, is older, which is a risk factor, just had an acute coronary syndrome, has severe significant obstructive coronary disease, has not been revascularized, remains symptomatic for angina, has LV systolic dysfunction, has a blood pressure that's kind of on the low side, has diabetes is not well controlled, the LDL is not ideal, and has also chronic kidney disease. So this patient, you would need to see early after discharge, make sure that you're targeting every single aspect of residual risk in this patient. And talking about inflammation in this patient, as this is kind of the topic of the podcast, this is a difficult patient to treat. I think that we know this patient is already high risk. Collecting a C-reactive protein may be of help or not, meaning that we already know this patient is high risk, and we don't really have drugs that are targeted specifically to lower C-reactive protein, at least not right now. Colchicine, which we've talked about being helpful in reducing cardiovascular risk after an MI or in stable symptomatic patient, is not ideal for this candidate because the GFR is impaired. And so when we talk about colchicine, we have to remember that the renal creatinine clearance is an important factor. And when we're less than 60 or less than 50, we should use colchicine cautiously. We need to remember about drug-to-drug interactions as well with colchicine. So this is a patient in whom colchicine can be considered, but very carefully. And you would think about a low-dose colchicine, the 0.5 milligram, which is the new formulation that is approved for atherosclerotic risk reduction. One may say, what's the difference between 0.6 and 0.5? Well, it's about 20% of the dose of the drug. And so in a healthy young adult with normal renal function, that 0.1 milligram may not be a big difference. In an elderly woman with impaired GFR, that 0.1 may be a difference. I will tell you, this is a patient that I would also screen for one of the ongoing trials. And the largest trials that are ongoing now are the one with ziltivekimab, which is a targeted IL-6 antibody, because again, we don't know exactly the risk-benefit ratio for colchicine in this population. And so if the patient fit the trial, that would certainly be informative. Of course, there's a placebo component to the treatment. The patient has to be comfortable. I run several different trials, mostly targeting interleukin-1. There's some targeting the inflammasome, some targeting CT14. These were all the possible candidates. But in the clinic, this is not an easy patient to treat. But again, back to what I said initially, remember the global mantra of this patient. Don't only focus on the inflammation, optimize the platelet-lowering drugs, optimize the lipid lowering, optimize the neurohormonal inhibition, consider drugs that have a secondary effect on inflammation, and bring that all together.
We thank you for this amazing and detailed teaching points. This is obviously a complex and extensive topic. I would ask you, would you summarize for our audience the key takeaways regarding the role of inflammation in atherosclerotic cardiovascular disease?
Yeah, no, absolutely. I mean, this has been a very fun discussion here. I think what we covered here is some primary prevention. So identify that inflammation is linked to cardiovascular risk. You can consider using inflammatory biomarkers like C-reactive protein, especially in the patient of intermediate risk. And if it's elevated, you can consider using a statin or like rosuvastatin or even aspirin in some of these cases where the risk is intermediate and enhanced by the inflammatory component. We discussed also how patients who have immune-mediated diseases like rheumatoid arthritis or lupus or others may have a risk modifier, and therefore the cardiovascular risk is higher than you would have without those conditions. When we talk about secondary prevention, we know that many of the treatments we do to target platelets, to target neurohormonal blockade, to target lipids, will also affect the inflammation favorably, which is great. We can think about using C-reactive protein or other inflammatory biomarkers to detect what we say residual inflammatory risk after the treatment. And certainly we've learned that colchicine, low-dose colchicine is effective in reducing the atherothrombotic complications in patients who have prior MI or had stable coronary artery disease. I'm passionate about research. I'd say let's stay focused on the research that's coming. We learned that CANTOS showed a significant reduction in events with canakinumab targeting interleukin-1 beta. I mentioned there are multiple phase 3 clinical trials with tiltadikimab targeting interleukin-6. They span from CANTOS-like patients with CKD to heart failure patients to acute MI patients in different trials. So I'm excited to see the results of this. I mentioned that I study a lot of IL-1 targeted treatment, particularly anakinra, Kineret, and we have ongoing trials in patients with acute MI and heart failure that I'm intrigued by it. We have now the opportunity going after the inflammasome as the source of these cytokines. So there's multiple of these drugs in the pipeline. I would say we didn't really talk about this, but I'd like to make a point to this, is we know there is a disease in which interleukin-1 is central. This is recurrent pericarditis. This is a condition where patients who have had an initial pericarditis event then fail to heal, becomes recurrent or refractory to standard treatment, which includes colchicine. And there is a targeted IL-1 inhibitor called rilonacept or Arcalyst that is FDA approved for recurrent pericarditis. So this is definitely a success for targeted cytokine therapy in cardiovascular disease. And again, we're following along experience with IL-1 blockers, particularly anakinra, in cases of myocarditis. There were several case series that came out during COVID and other chronic refractory myocarditis. It seems that blocking IL-1 may be beneficial. We need to stay focused for this research.
Dr. Abbate, thank you so much for your expertise. We've learned so much about inflammation during this episode and also other aspects of prevention and the importance of addressing residual risk. And these are definitely things I'm going to take away to directly apply to patient care. Earlier today, I had my first outpatient clinic as a cardiology fellow, and our discussions today are so relevant on multiple levels for so many of my patients. And it's definitely just a very exciting time to be thinking about inflammation and prevention with all these new trials and new potential therapeutic targets. So something we love to end our episodes with, Dr. Abbate, is a question that we ask everyone on CardioNerds. What makes your heart flutter about cardio-immunology?
Thank you, Gurleen, and congratulations for you in the start of this journey. I look back to my years in fellowship with a lot of nostalgia and joy, learned a lot, had a lot of fun, and really put the basis for what was my career to come. So, I mean, I'm a nerd at art. What really excites me is, understanding the mechanisms, connecting the dots, and this idea that you can interrupt a signal cascade by targeting a specific mediator and seeing the results. It's really what gratifies me. And so I've spent a lot of time in the basic science lab working with animals. And more recently, I spent time with patients in clinical trials. And when you can get a patient that is in distress, you can control it with a targeted therapy. It's incredibly gratifying. I just mentioned just now how the recurrent pericarditis field has changed. And so part of the most exciting time for me in clinic is when I have a patient who has recurrent refractory pericarditis, has failed multiple treatments, they have been multiple time hospitalized, seeing multiple doctors, and you can start them on a target therapy and they go in remission. That's really gratifying for me.
Dr. Abbate, that was such a spectacular episode. We learned so much, and there's so much that I look forward to listening back to on this, from the patient perspective, from a basic science perspective, from an emerging therapeutics perspective. This was a fantastic discussion, and couldn't thank you more for your time tonight.
Thank you very much. It was really a pleasure to be with you.